So, good morning, everyone, and namaskar, and welcome to the third day of our deliberations around patient safety. And Cygnia Healthcare is committed to zero harm, and that's why we bring in interventions which are, useful for nurses and nursing students, and most of them are pretty basic. I really hope that all of you are benefiting, and those who are not here, they will get a chance to view the video on our YouTube channel. So, the entire endeavor is called "In Pursuit of Patient Safety," and I think that is a continuous journey for all nurses and all healthcare workers because we want to serve our patients in a safe manner, and that's what Florence Nightingale told: "Do no harm." That is the first requirement. Now, for us not to do any harm to our patients, this is very important that we carry the requisite knowledge and skills, because sometimes if you don't have these two, you can make mistake even without knowing. So that's why we study for 3.5, 4 years, and even after experience, we still have to continue to study. So yesterday in the session, I told about, when we do the nursing and when we become a nurse, I know that probably I had learned just about 10% of what I actually needed to know to look after my patients very safely. That percentage may vary a little bit here, there, but it's very important that our basics are very sound. So that's why we have started this series of, very basic, uh, you know, topics which are very relevant for nurses, and once you have that in place, then you will be able to build as much of knowledge as possible on top of it. And today we are going to discuss about basic lab investigations, and that is going to be hosted by Ms. Ishita Chanda, who's a senior trainer working with Cygnia Healthcare. And let me introduce, I'll stop sharing my screen, and I'm going to introduce Ishita here. Ishita, I have known her for some time, and Ishita has finished her master's from CMC Vellore, very prestigious institution, and then she had 15 years of career in which I think she has donned almost all the very important roles of, not apart from being a bedside nurse, she had been a educator, quality nurse, then she had been ACNO, CNO. So she has done all of it, and I'm very proud to present Ishita to do today's session. So a very warm welcome, Ishita, and it's all over to you now. Let me give you the opportunity to share your screen and you can start. And thank you everybody else for being here, and a very, very warm welcome. And today is the last day of this 3 day series. So we will be having a little bit of chit chat at the end of the session, because we would love to hear from you what else you would like us to do. So it is nice to hear your voice. So we will do that once Ishita finishes the session and we stop recording. Then everybody can come on video and have a chat with us. So that's not a problem. So, in the name of patient safety, all over to you, Ishita, and a very warm welcome.
Thank you, ma'am. Thank you, friends. So let me pull up the presentation for today. Patient safety is one of my favorite, very close to my heart, a topic. And I think as nurse, as ma'am have already told, we in the course of our graduation, post-graduation courses, we learn 20% or 10 to 20% of what we have learned. Actually, that's theoretical. Rest 80%, actually, we learn from a patient and from our day-to-day life, isn't it? So that's amazing, and study or learning has no end. And that's why we call knowledge or learning is from womb to tomb till we die, till we go to the deathbed. Every day is a new learning, new thing that we discover in our life. So today's topic of on lab investigation, it is basically we are focusing on a basics. And one of another favorite thing which I personally like in my personal life as well as in my career was is Maslow's hierarchy. Maslow's hierarchy always talks about the broader aspect of the base is what? Air, water, sleep, food, shelter. That's what a human being requires, isn't it? So if the base or the basic foundation is strong, you can build up a long tower. If the foundation is weak, we cannot build a tower, it will fall down. So make sure, we want to ensure that all our nurses and our upcoming new nurses have a great foundation on what we are talking about is the basic, right? So today, as we'll be discussing on lab investigations, which are focusing with some case studies, and we will be discussing on the normal values of what we are going to do. It's going to be a brush up. And also, I would like you all to actively participate through your chat window. So I'll be looking at and viewing at the questions, the answers that you're giving it. So please mute yourself, your phone, and please keep your video off. That sometimes distracts the trainer as well as it may also work with the bandwidth in recording. And if you have any questions, we'll be happy to take it at the end of the session. And in the chat box, you can put down your questions at the same time. So every investigation, every lab investigations, they talk about a story or they tell us about a story. And I think we all love to hear a story. Till at this age of mine, I would love to hear some stories. Each story brings out new thinking, new aspects of learning. So our lab investigations also talks about and tells us about the story of what is happening inside the patient body, right? So here we go with the first question. Are you all ready? Okay. Which specimen is, okay, here. Which specimen is used to detect occult blood? And you have your options right there. Select your option. You can have a paper and pen with you. Please note down and jot it down. I want to put it in the chat box. You're free to do that also. I hope this is pretty easy question. I think you all have marked it. So let's see what is the right answer. Right answer here is stool. What is occult? Any idea what is occult? Occult means something which we cannot see with a naked eye. Blood is something we can see, but in stool, we cannot see that. It gets mixed up, right? So in sputum, when the patient, can I request all of you to keep yourself muted? Since sputum, when the patient, brings out the cuff, it is obvious we can see the streaks of the blood. And, in stool, it becomes difficult. Now, I'll tell you a story. This happened like a child of 3-year-old was, gradually the mother noticed that he was becoming a little pale. And so when he was taken to hospital, the doctor have done a lot of investigation, hematocrit, etc., everything related to find out what is actually causing this child. And the child was anemic. So the mother was a known nurse, and she said, why don't we focus on the basic investigations? And she insisted on occult blood test to be done, and the occult blood test report came as positive. So that was that. What does it indicate? That what does occult blood mean in the body when we find? That means there is somewhere bleeding, and bleeding in the GI tract. There could be polyp, there could be hemorrhoids, there could be fissures, there could be ulcerative colitis. All these, if there is an internal bleeding, so GI bleeding, it will be in occult blood. So if you have marked yourself correct with the B answer, so please a self clap or a self pat for yourself. Okay. Next, moving to our second question. Okay, so which of the following test is more specific for myocardial damage? Please read the question carefully. Which of the following test is more specific for myocardial damage? And the options are here. You have the options. So please, can I see some answers in the chat box, please? So I'll know. So what is the answer? Okay. Anybody else? We have 60 participants. I can see only 3 people answering well. Okay, that's good. So here comes the answer, CPKMB. Let's talk about this. So many of you may be, student nurses, could be freshers. So CK is creatine kinase, is an enzyme that is found in the muscles, okay, and the tissues in the brain. Usually, when can we see this? This gets activated when there is an injury in the muscles tissues. So we have CKMB, that is an isoenzyme of cardiac isoenzyme. We have CKMM, which is an isoenzyme for the muscles. And we have CPKBB, that is the isoenzyme for the brain. So a typical, USP of CPK is it starts working, it starts raising its level after 6 hours of injury. And once the injury has occurred 6 hours, it started gradually increasing. It reaches to a peak at 18 hours. And slowly it peaks down. It comes down by 2 to 3 days. So even if your patient had a myocardial injury or an MI, a mild MI, we can still do this blood test and find it out that within 72 hours, did the patient have any injury? Okay, so CPKMB is the specific when we are talking about myocardial damage. The rest are not. ALP and SGOT is your liver events. CPK is actually a general CPK which has all the three isoenzyme. And okay, so well done, good. Those who have answered, Vivo, Radha, and others, well, good. Moving further. Okay, so what is the third question is the very, very easy this one. Okay. Normal fasting blood sugar level. So let's see, if I don't give an option, what will be your answer? So write down in your answers for the normal fasting blood sugar level in the chat box. I'll not give options. Let's see. Without option, how many of you could write the number? Can I have some answers in the chat box, please? No answers? Okay, okay, good. Getting some answers, yes. Okay, so well, just to stop with, I can see 80 to 120, 80 to 110, 80 to 110, 120. Yeah, fine, everything is fine. 70 to 110, we also am getting it. These numbers doesn't have any value if you don't write the digit. Am I right? 70 to 100 or 110, is it kilometer, kilogram, milligram per deciliter? What is it? So as nurses, please remember, yeah, someone have just written mg dl. It is mg per dl, right? Okay. So the options were here, less than 120 milligram per deciliter, and others are there. So the right answer, which is very close to what you all have written, is 70 to 100 milligram per deciliter. Now, one thing I want to stop here and tell you, these numbers does help us to identify what's going on with the patient. But please note that each patient is different. Their manifestations to their problems are different, right? Our perception towards things are different. So a patient may be okay, maybe having showing symptoms of hypoglycemia when he or she is with 70 milligram per deciliter. Or some patients can even manifest hypoglycemic symptoms at an 80 milligram per deciliter. So please know your patients well, because each patient has its own story it talks about. So we need basically to do any fasting, blood sugar, minimum of 8 hours of fasting is required. And we all know that glucose is a very essential part in keeping energy, providing energy to the cells. And it is a monosaccharide, and it is being broken down by liver to glycogen and gets stored. Okay. So that's good if you have marked it correct. And those who have written in the chat box, absolutely correct. Bravo, well done. Very happy that our nurses are pretty smart, That's great. Which of the following tests is to be evaluated in order to assess risk for cardiovascular disease? Now we are going to identify what are the tests that helps us to identify that the patient's heart is not in a good condition. Here are your options. So can you write down some in the chat box? Which is the test? Which is the option do you think is apt to identify risk for cardiovascular disease? Chat box, chat box. If you can just write down option A, B, C, D. Yes. B, B, okay, A, B. Anybody else? A. So we get a 50-50 of A and B. That's what I understand. And many of you are still confused. So LDL is, what is LDL? LDL is low density lipoprotein and HDL is high density lipoprotein, right? So just to exclude, hematocrit is a study of your bloods. So basically on RBC, hemoglobin, your CBC will not tell anything about your cardiovascular risk. So excluding B and C, we have A and D option left. Okay. LDL, your low density lipoprotein, is actually harmful and it is known as a bad cholesterol to the body. Whereas HDL is a good cholesterol, and that's what protects our heart, okay, from myocardial injury or a heart attack. LDL, the normal range. Anybody remember what is LDL normal ranges? Is actually we try to keep it less than 100 milligram per deciliter. And sorry, and HDL, we tend to keep it above 60 milligram per deciliter. So LDL and HDL. So in our body, we have good as well as we have bad cholesterol. So that's how they're working, compensating the cardiac activity of the heart. So what is VLDL? VLDL is very low density lipoprotein. This is more dangerous. Okay. And what happens is this VLDL causes atherosclerosis. Atherosclerosis is where there's a fat deposition in your artery or your blood vessels, and that keeps you at a higher chance of getting MI or a stroke. Okay, so that's how it is. That is very important when we talk about the lipoproteins. I hope it is clear. So the right answer is LDL and HDL. Okay, that's good. Let's proceed. So the fifth question, which is good cholesterol? I think I don't need to give any option for it. Can you write down in the chat box, because we just now discussed the good and bad cholesterol. So which is the good cholesterol? Can you just type it in the chat box? Yes, Hepzibah, Stephen have written something. Juna has written, Vinita Mole. Good. That means you guys are really actively listening, okay, to the session. That's great. That's great. Very good. So the options are here, and the right answer is your HDL, which is considered as the good cholesterol. And as we have discussed, we would love to keep the level more than 60 milligram per DL, right? So that's about the cholesterol. We have another question. Okay. So when do we say that the patient is having hypercalcemia? Your options are here. Okay. So have you marked your answer, which is the right answer? Can you write down those options? Okay. Somebody said B, some said C. Some said B. I see repeatedly only those who are actively listening. I think they are writing. What about the rest of you? B, B, C, B. Okay. Well, so this is very clear that you people are able to identify that it is hypercalcemia. Simran, you have somebody, can you mute yourself, please? I can hear baby crying. Okay, some have written. So, my dear friends, we are talking about hypercalcemia. The word itself has the electrolyte level, which is calcium, right? So it is B and C. It should be between B and C option. Potassium is hyperkalemia or hypokalemia. So do not misunderstand with these two terminologies. So A and D will be excluded from these options. Okay. So I'm correct. Majority of you have given the right answer. That is calcium level more than 10.5 milligram per deciliter. So what is a normal calcium level? The normal calcium level is 8.5 to 10.5 milligram per deciliter. Let's discuss how this hypercalcemia occurs. You know what happens. So this calcium is being produced in our body by parathyroid, and there are small 4 parathyroid glands which are situated in the anterior part of the neck, and they produce it, right? Due to some problem, maybe there is a tumor sitting in the thyroid that is suppressing the, the gland, and there's a hyperproduction of our calcium in the body. Now, if calcium goes high in the body, absorption is not taking place as much as the supply is coming. So what will happen? This extra calciums will get deposited. It will deposit in the bone, making the bone more fragile, and you become more prone for getting any fractures. We also had stones, calcium really, they get accumulated and they form some stones in the body. And we know that calcium also causes some cardiac arrhythmias in the heart, some changes in the heart. So these will be the manifestations you can see when we talk about hypercalcemia. Now, why am I taking some time to discuss how it is happening and what is a normal value? Because once you get the report in hand, think what is happening in the patient body. You know where it is being produced. Ask the patient about history. Is he or she taking calcium? So we know that most of women are deprived of calcium and vitamin D3, especially in India. So we have been prescribed calcium. But do you teach your patient that when you are taking calcium, you should give a gap of 3 months. Either you can take 9 months continuously and have a break. Especially we give the break in the summer season, and we can tell them to stop for 3 months, or you need to teach the patient that take for 3 months, give a break of 1 month, again 3 months, give a break of 1 month, like that, right? And when a patient is been prescribed to have calcium test, before you collect the sample, ask the patient, did he or she take calcium tablet? If he or she is on supplements, we should stop this calcium supplement or vitamin D supplement for minimum of 3 days before you collect the sample for calcium, right? And this is being taken as a fasting. We can take it as a fasting. Another thing is, when a patient is on calcium, or when you're taking a blood sample for calcium, you need to know certain things about the drug interaction. Is the patient on any anticonvulsant drugs? They usually interfere with your calcium level. And also, if the protein level is low, the calcium level gets affected. So these are some in the back end of your mind. Should be thinking, should be questioning. The more you have reasoning in your mind, the more you get onward. Anita, can you just keep yourself muted, please? Okay. So this was on our
Just
hypercalcemia.
hold on, Ishita. I'm going to mute all, and then you can unmute yourself so that we don't have any problem, because people
Sure.
are on and off putting it on.
Okay, ma'am. So here we have.
Please unmute yourself.
Yeah, yes, ma'am. So you have a patient who is complaining of severe, you have a patient who is complaining of severe diarrhea. And you notice that he was initially oriented, but now at present, he is not well oriented and he's behaving and talking something irrelevantly, some irrelevant talk. So you just checked he was for his blood samples were taken today for some electrolytes levels to be checked, and you notice something in his electrolytes level, and you come to conclusion that it is because of this electrolyte which got deranged, my patient is behaving such such behaviors is being shown in the patient. So what was it? So you have your options here. What do you think that happened to this patient? Have you marked it? Okay. Can I see some answers in the chat box? Okay. Radha and Paul, Ruth. Okay. Well, you know something, when I was preparing for this, it was just like a flashback because 2 years ago, my father was battling with cancer and he manifested exactly this signs, this symptoms when he had. So he had electrolytes deranged and it was very difficult for us to manage him. He went in a running car. He was trying to unlock the car and he wanted to open the door and get down, It was very, very difficult. Patient himself doesn't understand what's happening. So this was basically because of hyponatremia. So we are talking about hyponatremia, that means low sodium level. So the normal sodium is, how much is a normal sodium level should be? It is between 135 milliequivalent per liter to 145 milliequivalent per liter, right?
ऐसे लग रहा है मेरे को नहीं आप भी तो कहाँ वापस आते हो उस दिन आपने कहा कि I'll come back and you never came back.
Ma'am, can you mute yourself if you don't mind? So what happened here was hyponatremia. So sodium is one. What does sodium does? The sodium actually maintains us acid-base balance and it maintains the osmotic pressure in the body. Okay. So when there is a hyponatremia, the sodium level is going down.
No, I cannot be doing this.
So when the sodium level has gone down, what it causes is your osmotic pressure also changes. It affects the CNS. Now, sodium also plays a vital role in conducting the nerve impulse from nerve impulse. Okay, so it is affecting your CNS level. So once it is affected, it causes cerebral edema. So when there's cerebral edema, it's getting, there's edema. So ICP is increasing. So when there's an intracranial pressure increase, the cognitive level, the level of consciousness, everything gets deranged. And in severe hyponatremia, we can see even patient exhibiting seizures. So anticipate when a patient is dehydrated, when you get a patient in ER who is severely dehydrated and coming with a lot of fluid loss, maybe vomiting, diarrhea. Please check your electrolytes level because this patient could be a very high case of a hyponatremia. Okay, so here, I hope it's clear to all of you. Next, we move on to D-dimer test. It is a blood test that measures DASH that results from the degradation of fibrin. What are the options? Here are the options for it. Okay, so answers, any answers for this? Some pretty smart frank colleagues of mine have written the answers fast. Any other options? B, 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 C, B, C. Great. So there is a confusion with B and C, B and C. Okay. Okay, okay, okay. Well, let's see what is it. Okay. The answer is C. D-dimer is a test. We do it to identify whether you have any abnormal blood clotting related disease or not. Okay, so fibrin is what? Fibrin is a protein that helps in clot formation, and fibrin lysis is the process which prevents the clot from getting it larger or growing in size. So D-dimer tests usually we do for patients who are at risk of DVT, deep vein thrombosis, pulmonary embolism, or DIC, disseminated intracoagulopathy. So here what happens is this test, I'll again tell you a story, because I've been a nurse for 15 years, but sometimes, when it happens to your own family members, you get a thought block, right? So my father was suffering with lung cancer, and it was he had SVC syndrome, that is superior vena cava syndrome, and his upper body was getting swollen up completely. So he was in an inoperable stage. So the only option left for him, so that the heart is pumping hard, but there's an obstruction, the tumor is growing big, pushing your SVC, so blood obstruction. So what they did, they wanted to put a stent. So first time they said, why to put a stent? They will do a ballooning. So they did ballooning. Within 12 hours of this procedure, my father started having syncope attacks. Suddenly he's talking and he's rolling his eye and he's becoming like, so what happened? He was fine all of a sudden. So I thought, is he getting a cardiac arrest or what happened? It was a very, part which we cannot take it. The doctors said, post procedure of a stent or a ballooning, let's know whether we have any PE, that is pulmonary embolism. Was there any thrombus which got, in the lungs or somewhere in the brain? And we did a D-dimer test. Now, again, I'll tell you what happened. The D-dimer test was positive. Okay, so the normal value is less than 500 nanogram per deciliter. Okay, milliliter, sorry. And his was something 800 or something. So he was very positive with D-dimer test. I became very panicked that is it P? Even the junior doctors, yeah, we could be, it is, he's suspect of P. But later, for some time, we forgot that he is already on heparin. So when a patient is on heparin therapy or in a coagulation therapy or in a blood thinner, D-dimer test reports is always in a higher and it's a positive. So again, why I'm telling you the story is just by looking at the test, yeah, positive hai, negative is there, or it is high. Again, see, know, and check what the patient is taking, what food he is taking, what medication he's taking, because there are a lot of drug to drug interactions and a lot of investigations depends on the drug that you're taking. So D-dimer is again a test, just to repeat that it is to identify any bleeding disorders that is taken in the body. Okay. Next, moving forward, we have the next question. A patient's complete blood count CBC results are back. Which result demonstrate polycythemia? So here is polycythemia, and this is your options are here. So can you all write quickly in the chat box? What is the right answer? Yes? Yes, friends, just write down. Let's see. Polycythemia. No answers till now. What happened? It's very easy. Somebody, Melvin wrote B. Okay. Only Melvin wrote, nobody else? Anybody else? Try it. It's okay. It's okay. We are here to learn, right? B. Okay. A. So I'm getting everything. Oh, somebody have written ABCD. Okay, I have no option of ABCD also. Okay. Well, this sounds to be a little bit, I think let's talk about it. Polycythemia. So you remember first year when you joined nursing, I still remember my teacher who taught me the medical terminologies and how to identify what disease is related to. Poly means multiply, more. Cyte means cell. Chemia means blood. Okay, any abnormal condition in the blood. So there is abnormal increase in the blood cells. So here the right answer, yeah, now I'm getting every right answer, is A, hemoglobin. So what is a normal hemoglobin for a female? In India, we say 12 to 14 gram per deciliter. For a male, we say 13 to 16 gram per deciliter, right? So what happens if there is overproduction? Why it is production of increased volume of blood or RBCs? Could be because there is some problem in your bone marrow. There's increased production of RBC in the bone marrow, or there could be inherent diseases, okay, conditions, or it can have HIV also, or some tumor. All these things can cause polycythemia. Okay, any doubt till now? So polycythemia is increased volume of blood, so that is what is polycythemia is. Good, well done. Next, we move on to, okay, again, a question related to CBC. So you're assessing a patient's CBC, which lab results below demonstrate leukopenia. So here are your options. Please put it your answer in the chat box, your options. Let's see. No answer till now. Okay, Juna have just mentioned. Read the question, read the terminology, you will get the right answer. Okay, so when we talk about leukopenia, we are talking about which part of our blood? We are talking about WBC, right? So again, exclude option B and C from here. So what is a normal WBC count? Can someone just write down in the chat box what is a normal WBC count? Anybody quickly? Okay, so the normal WBC count is between 5,000 to 10,000 per cubic millimeter. Okay, so here we have is leukopenia is lower WBC. Okay, lower WBC count. That is called leukopenia. And if the WBC count was more than 15,000 per cubic millimeter, we call it as leukocytosis. Okay, leukopenia is lower. Now again, what does WBC does? WBC works as a fighting agent. It builds up the immunity, right? So if your immunity part to fight with outside microorganisms, if you will lose the battle, and finally you will get all the diseases from outside, right? So which are the cases when you think that WBC reduces, WBC counts reduces? Any idea? When there is a bone marrow suppression, any autoimmune. Okay, so we have this autoimmune diseases also, right? So okay, I'll just correct it. It is WBC is 3,000 per cubic millimeter. It is okay. It is just a typing error. Just correct it here. So when WBC count is lower than 5,000 and it is called as leukopenia, there could be there could be, anemia, and there could be a tumor that is suppressing the bone marrow, and the bone marrow is not able to produce that much of your WBC. So there is a suppression of it. Okay. So that's a case where we see, and more oncology patients, especially with aplastic anemia, ALL, CML, all these cases where the WBC counts are low and they are very high prone to get infection. Okay. So next we're moving on to again a part of our CBC where we are talking about thrombocytopenia. So what is thrombocytopenia? The options are here. Right, can I see some answers in the chat box? Vinita has answered. Okay, good. So we are talking about, I think now you have understood the previous question, you all had confusion with WBC and platelet. Here it is platelet. We are talking about thrombocytopenia. Okay, so platelets helps in clotting the blood. So thrombocytopenia is related to platelet. And what is a normal platelet counts? Anybody can write down in the chat box. What is a normal platelet counts? Though it is not here, but if you know the normal, then only you will identify that when we are discussing about thrombocytopenia. Can someone just write down what is the normal platelet count? Right. Very good. Radha, Vinita, good, good. Okay, so platelets is usually we take 1.5 to 4.5 lakhs per microliter. Okay, so here what is happening is our platelet count is low. So it is 80,000. So what will the patient manifest with? The patient will have bleeding. The patient with little bit of injury or cut, you see they get bruise mark, they get bleeding, and the bleeding may not stop for quite a long time. So thrombocytopenia is related to platelets, and thrombocytosis is when the platelet count is more than 4.5 to 5 lakhs per microliter. Usually these reports, these tests on CBC helps us to identify when we are talking about blood cancers or any suppression of any infection, any disease that is occurring in the patient body. Moving on to the next is, what is BUN, or we call it at times BUN? What does increased level of BUN indicates? So here are your options. So just quickly write down what is BUN stands for and what does increased level of BUN denotes or indicates. Anybody in the chat box? Okay. So BUN stands for blood urea nitrogen. So let's understand what is this. So what is urea? Urea is produced by liver in the urea cycle. And this urea is actually the end product or the waste product of protein, which is being consumed by us in the diet. And further with the digestion, urea is being formed. Now, this is a waste product and it needs to go out of the body. So when any waste products are not going out of the body, that means something is wrong. Okay, and which organ is responsible for excreting the waste product from the body is kidney, right? We all know. So in kidney, we have a filter. That is, we call it glomerular filtration rate, or we call it a GFR. Now, GFR is actually the how much amount of blood is being purified by the kidney in 1 minute. So usually the normal GFR is 60 or above 60. But if you see that your patient is having GFR less than 60, okay, that is giving you an indication that my patient's kidney is not functioning well. That is giving you an alarm that something wrong is happening to the kidney, right? So this is what BUN stands for and what does it indicate. Okay. So your right answer, most of you have written the correct answer. Well done. I'm very happy that you are all very up to date and keeping your knowledge updated also. That's great. Good. So moving further. So we have a patient who has to undergo CBC and fasting sugar. As a nurse, what instructions should you be providing him? Remember that your patient is a known case of diabetes. So what are the instructions you should be giving? So your options are here. So you can read your options and let me know what do you think is the apt answer that you should be giving, or what should be the instruction that you'll be giving to your patient. Some quick answers in the chat box, please. Right. I think most of you have got it. Correct answer. So here the option is A and B. We know that, especially fasting sugar, any fasting, we need minimum of 8 hours to maximum of 12 hours that we need to be taken care of, that the patient is in fasting. And since the patient is a diabetic, you need to explain the patient that the patient is not to take any insulin or any oral hypoglycemic medications till the blood sample is drawn. And please remember, this part is one of the very, very important. I have seen most of my nurses doing some getting error. This is because we often tell the patient, but we often forget to get teach back. That means ask the patient, did you understand? And if he says yes, tell him or ask him or her, what did I tell? So if he or she repeats the same thing, what you have instructed, that means yes, your patient have understood everything correctly. Now, coming to another mistake of that we often do is, once the sample is taken, we forget to come and tell them that now you can have your meal or you can have your medicines ready. Most of the time, the patient keeps fasting for a long time and say, the nurse told me that it will be fasting and the blood is taken, but she didn't tell me whether I should take now or not, because they trust that whatever we say is correct. So remember, even when you say them to withhold with anything, when the order is being taken back and once he can take his normal diet or food or medicine, please go back and ensure that he or she takes the meal also. Okay, so that's what we have to remember. Communication is very, very important for our patients. DASH is the normal level of serum protein. Very easy. These are the options. We are talking about serum protein, and what is the answer? Anybody? What is the right answer? What is the normal serum level of protein in the body? Any in the chat box? Quickly, quickly. No answer? Okay, let's see what is the right answer is. The right answer is, it is 6 to 8 gram per deciliter. That's a normal serum protein level that we require in a patient. Now, protein. What is the role of protein here? Serum protein is usually what we measure is the amount of albumin and globulin present in the blood, right? So it regulates, protein helps in regulation of our oncotic pressure in plasma. So it prevents the water from leaking out of the blood vessels. So what happens? Have you seen hypoalbumin or hypo when the albumin level is low? Okay, what happens to the patient? What type of symptoms? How does the patient look? Doesn't the patient look edematous? Sometimes we see anasarca, that is full body generalized edema. Why? Because the protein level is low, albumin is low, so the water is coming out from the blood vessels to your extracellular tissues, getting accumulated. So whenever you have any patient coming with edema, look into the serum protein and anticipate that what is the patient is having, right? So we have a patient here who is on heparin infusion, and a doctor has asked us to send sample of APTT. Which of the following nursing considerations will you keep in mind? So here are your options. So read carefully and then quickly put it in your box. So what do we do when a patient is on heparin infusion? What are the things that you need to keep in mind, though the doctor has told you the sample to be collected for APTT? Any answers in the chat box? Okay, only one person have answered. So here we go. The right answer is A, B, C, D. We do not draw sample from the same arm in which the heparin infusion is going on. We take it from the opposite arm. The reasons behind all these is because the concentration of heparin in the blood will be high. So your sample, the report will come wrong. Okay. B, if the client is receiving intermittent heparin by intermittent injection, plan to draw the sample 1 hour before the next dose of heparin. And this is how we do for any drug level check. We always take the sample 1 hour prior to the next dose of our medicine. So when the next dose of heparin comes, just before that, priorly 1 hour before, we need to take the sample for it. Blood specimen again should be transported to the laboratory immediately. Yes, because if we are going to check the clotting factor, we don't want the the blood sample to get clotted. Okay. So we also need to check for any APTT value which is longer than 90 seconds. Now, what is a normal APTT level? Anybody can write down in the chat box quickly what is a normal APTT level. Then only we'll know that why we are talking about 90 seconds. Anybody? Quickly, what is the APTT level? Nobody? Okay, the normal APTT level is between 25 and 35 seconds. So if the normal is between 21 to 35 seconds, here we are talking about 90 seconds, which is quite a longer period. Okay, so that's giving again that it is taking long time to get clotted. So what is the problem? Is my therapy effective or not? Okay. E is not an option because APTT should be between 3.5 and 4.5 times normal than the client that is receiving the heparin therapy. It is not 3.5 and 4.5. It should be 1.5 to 2.5 times of normal, especially when a patient is receiving any heparin therapy. Okay. So hope it is clear. So next time when you're taking a sample for a patient who is on heparin infusion, I'm sure you will keep these in mind, okay? And you'll remember that what we have discussed in the class, right? Mr. X is a known case of seizure patient and is on tablet Dilantin for past 5 years. On his routine checkup with his doctor, he has been prescribed to check his therapeutic serum medication level, that is of tablet Dilantin. His report shows phenytoin, or that is Dilantin, is 30 microgram per ml. What do you think his report is telling us about? Any idea? Is it normal? Is it high? Is it low? Or it is none of the above? So if you have marked it, so this is a high level because a normal Dilantin is 10 to 20 microgram per ml. This is a normal rate. Now, why we are talking about therapeutic drug level? it is very important that any patient who is on long-term drugs, especially if it is on digoxin or any digitalis, any anticonvulsant drug, we need to know what is the level of drug that is being absorbed in the patient's body. Is it under or it is overdose of the medications that we are giving? So we need to know, is the patient getting the right dose and the right amount of medicine is being prescribed or not? Because too much of medications in the blood can lead to fatality at times. So need to check on long-term medications, the therapeutic level of it. Okay. Next, we have a patient who is receiving a drug called as Diarrhea or tramterine for hypertension, and the nurse looks for signs of hyperkalemia. Which of the signs point us to that patient is having hyperkalemia? Okay, so just to give you a brief of this drug, this is a potassium sparing diuretic. Okay, so what happens here is when we are talking about a potassium sparing diuretic, they try to retain potassium. They don't want to lose the potassium. Now, over again, the use of this drug for a longer period of time, potassium is getting accumulated too much. And if you are a case of a CKD patient, is not getting washed out. So this gets accumulated in the body. And finally, what happens, the patient will manifest hyperkalemia, which is a very dangerous, because again, we can see arrhythmias in the patient. So all this, what we can see on the screen options, the patient will have cognitively disbalance, will have tingling sensation of the hands and the feet, will have anxiousness, weakness, and also at times we can see cardiac changes are also seen in the ECG. So all these are the signs of our hyperkalemia. Now, again, I'm saying whenever you're taking a patient history, to identify what drug the patient is taking, how much it has to be taken, what long-term medication he is taking. And that will give us that, why is the patient anticipating like this? Why is the patient throwing, like this behavior? Know the drugs, ask the relative, show me the drugs, because most of the time they don't know the name. At least they can bring the drug, you can check it, because these are small things. As a nurse, they're very crucial to know. Most of the time they get overlooked by our doctors, but as a nurse, we should be very careful when you're taking the history of the patient. Each and everything, minute details are very important. So here we have a patient, Mr. Y, who is fasting. Mrs. Y, who is fasting for his routine blood investigation that needs to be done. So the nurse have told that, that you are fasting for the blood test. Next day morning, you are supposed to give blood for sample. Okay? She feels very thirsty in the morning. Now she is in a dilemma whether she can drink water before the blood sample or not. So can I have some answers in the chat box? Can Mrs. Y drink water? Yes or no? Quickly in the chat box. Quickly in the chat box. Only 2 people have answered. The rest, I don't know whether it's right or wrong what they are writing. So I have a mixed answer. Good. So the options here was yes or no. And yes, the patient can drink water. Water does not have any effect on any of your blood investigations. We are talking about general blood investigation. Please make a note of it. I'm not talking about any of the investigations, radiological investigations. That is different, but we're talking only about routine blood investigations. And in that, if the patient is thirsty, patient can take a little bit of water. That is no harm at all. And the more the patient is getting, hydration is better to be maintained in this patient. So next time, remember, yes, the patient can drink water. Okay. Mr. Y had just received his reports on coagulation profile, and his PT report is 23 seconds, and he does not use any anticoagulation. So what does his report denote? Is it something abnormal or everything is in the control level? Any answers? PT is 23 seconds. Any answers in the chat box? What is the option? Okay. Only one. Juna have answered. Runa, okay. So the normal PT is 11 to 13 seconds. Okay, the normal PT level is 11 to 13 seconds. And here we are talking about 23 seconds. Now, 11 to 13 seconds, which I said, is actually for a normal human being who is not on any anticoagulation therapy. Okay, so it varies based on your patient's medicines, if the patient is on any coagulation therapy. So here we see it is high, 23. Okay, it is high. I'm talking about PT, not APTT. It is PT, prothrombin time. So it is actually high and it is a critical value. So when we call it as critical value is when the PT report is more than 20 seconds, it needs to be seeked immediate action, and bleeding prevention protocols all needs to be followed at place, and it has to be placed on time. Okay, so we don't want to lose the patient on severe bleeding, right? So here we have another patient, ingestion of which of the following leads to elevation of serum bilirubin. Now a patient is there, or there are multiple of patients whose serum bilirubin level often gets affected if they have or they are on such drugs. When you're sending the sample and when your serum bilirubin level comes, again, numbers are good. Numbers will tell you, but need to know what was the patient taking? Is the patient with such and such diseases or any diet or any medication? So any idea which of these drugs can cause or elevate your serum bilirubin level go high up? So the answer is all of the above. All of these: alcohol, morphine sulfate, theophylline, your aspirin, they are hepatotoxic drugs. Even remember your lipid lowering drugs that we use, they are all very hepatotoxic, and over the use of these drugs can cause increased serum bilirubin level in the blood. So my dear friends, we have come to the end of our Q&A session today. These were just a snapshot of what on our basics that we have learned. My takeaway note or message for you all today is, please pay attention to certain things. Always remember, numbers does tell us a story, but behind the story lies your knowledge, how much you know your patient. You need to know what drug the patient is on. Is the patient taking any medication, over-the-counter medication? And also, some very important thing is drug and food interaction. So I'll give again an example. Since this PT, APTTR was something very close where I was working in oncology as well as I've seen my father. You know, if a patient is on a blood thinner, okay, we need to give health teaching, and often we miss out the small important thing when we talk about drug and food interaction. Vitamin K that is found in the leafy vegetables. Now, if the patient is taking heparin, okay, or taking Clexane injections or any blood thinner, and the patient is also taking leafy vegetable, thinking that leafy vegetable gives a lot of iron and I should be taking more of it. But leafy vegetables contains vitamin K or vitamin K. So what does vitamin K does? The vitamin K absorption increases when we take this leafy vegetable. And if vitamin K increases, gradually the prothrombin time shortens. And that's not what we wanted, right? So again, that will work as a counterpart of the drug that we are giving the patient to keep the prothrombin time within the normal range. So know the drugs, know the medications, what the patient is taking. And here comes a bonus topic for all of you. So what are the type of coagulation tests that we do? There are three types of coagulation tests. One is PT, that is prothrombin time. What are we trying to find out when we talk about prothrombin time? It helps us to identify what is the ability of the clot, like how is the clot formation taking place, and that is within seconds. Within how many seconds the clot formation is taking place, right? INR, that is International Normalized Ratio, INR, it ensures that the result from a PT test are the same from one lab to another. We cannot say that lab is good, this lab. Correlation of the lab reports all across talks about whether we have the uniformity in that or not. And PTT, or partial thromboplastin time, it determines and helps us to know how effective is our blood thinning therapy is going on. When we are giving any blood thinner to the patient, we need to know, right, how effective is it? So do we need to taper the dose, increase the dose, decrease the dose, or change certain thing, modify it? Is all based on our PTT. So hope you have understood the different coagulation tests that we do for our patients. And thank you once again to all of you and Tankam ma'am for giving this opportunity. I hope you all have learned something new, or you would have learned, just got brushed up. We all know that more we learn, the more knowledge we share, the more we gain. So something which no one can take away from us is actually our knowledge. Am I right? So with this hope that whatever you have learned today, you will practice that, in your day-to-day life. You will apply that to your patients as well as in the future nurses, those who all of you are senior, you have to groom and nurture the new generation nurses who are yet to join nursing and those who have come. We need to help them to bloom to a better nurse that we want to see in that. The lacunae that we have, we want to see it. And, we want to learn from our patients. Whenever you're taking care of patients, think, question, rationalize it. I used to love my night duties. That's the time when you used to look into the, all the lab investigations, and you will see this used to be graph. I don't know. We used to write down all the investigation and we'll say, okay, ye kyun बढ़ गया है? इस दिन क्या हुआ था? Look back to the chart, telling us what has happened to this patient, why the potassium level went up, what was the manifestations that he has shown. So this is all about from my end. If you have any doubt, and Tanka ma'am is here and expert, she will definitely add on from her bucket of whole knowledge. Okay, thank you.
Thank you, Ishita. Thank you, everyone. And before I stop the recording, one last message. In your life, you want to learn and you want to learn it free. Just start asking why. When the doctor writes something, ask the doctor why. When your senior is telling something, ask why. When the tutor, your lecturer, anybody is telling you something, just ask them why. If you know the rationale, your critical thinking is going to really shoot up, because that's where most of our nurses are pretty weak, is to put everything together and decide what is happening to the patient. So it's very important to ask, and as Ishita told, when you're on night shift, start asking questions in the patient's file. What happened to this patient? Why this went up? What was the story? So I really hope that all of you enjoyed these 3 days and we could help you with some basic knowledge, and all the recordings will be available on our YouTube channel. So you can always go and revisit the recordings, or maybe you can tell your friends to come and attend. And with that, we will say a very big thank you from Cygnia Healthcare, and we will come up with more such useful interactions in future. Don't go away. We'll just talk to you in a minute. For the recording's sake, it is by now. Okay.